Intravenous therapy, anatomy. The digital veins are along the dorsal part of the hand, the top part of the fingers. And if they're large enough, they can accommodate a small gauge needle. However, they should be used as a last resort when selecting a site for an IV. The metacarpal veins are going to be formed by the union of the digital veins. They're usually pretty visible and they lie pretty flat on the hand and are very easily to feel. They're also easily accessible. So the hand is going to provide a pretty flat surface for stabilization. So this vein in the extremity allows successive venipunctures to be performed above the site. These veins can be used as a first choice for venipuncture. When using them, however, you need to keep in mind the distance from the insertion site to the prospective catheter tip because you don't want that tip to be positioned in the wrist area. And it is preferred that the wrist is not immobilized. So it's really necessary to consider the impact that limited ability is going to have if you start an IV in the hand. Patients require their hands to support position changes, to use crutches, walkers, and it can be very awkward sometimes to have that IV in the hand. A cephalic vein is the vein that flows upward along the radial aspect of the forearm, and its size can readily accommodate a large needle while its position provides pretty easy access and natural splinting. It can be accessed from the wrist to the upper arm using the most distal region of the vein first. In other words, you want to start as close to the hand as possible. Now, these veins tend to do what we call roll, so you really have to anchor that vein during the venipuncture. The accessory cephalic vein is going to ascend the arm and it will join that cephalic vein below the elbow. Again, its large size can accommodate a large needle for those infusions that require the larger needle. The basilic vein is going to be along the back of the arm. You pretty much have to bend the elbow to see it. It's really large and it's usually pretty prominent, and the vein can accommodate a very large needle. Again, this vein tends to roll during insertion, so it has to be stabilized well during venipuncture. The median antibrachial vein can be really difficult to palpate and actually to find it because the size of this vein will vary from person to person. Usually you can spot it on the ulnar side of the inner forearm. It isn't used as a first choice because venipuncture in the inner area of the arm is definitely more painful, and it's also has a close proximity to a nerve. The median cubital vein lies in the antecubital fossa, and we don't use this for routine IVs except in the event of an emergency, or we're only going to have it there for just a brief period of time. We do use this to draw blood most frequently, but when you put an IV in the fossa of the elbow, it's going to be subject to bending quite frequently, so you have to immobilize that joint. So again, it's basically a last resort for routine IV therapy, and we also have to be concerned about an accidental arterial puncture in this area. So again, when you start an IV on a person, you want to start as distally as possible, because if something happens to that IV and it infiltrates or it gets pulled out, you cannot start an IV distal to that site. So basically, you have to go above. You start low and you work your way up. So there's several things to consider when you're selecting a vein. You really need to consider the reason why the therapy is being ordered. Is it for hydration? Are we going to administer drugs? Do we need to administer blood or blood components? Is it going to be an IV line for a preoperative procedure? So does it need to be in a large vein to accommodate the flow of fluids, the viscosity of the fluid? We also need to consider the potential for extravasation. Is the fluid we're planning on administering going to be caustic to the tissues itself? So what size vein do you really need? You also need to be aware of the characteristics of the available veins. What size are they? Where do they go? Are they soft or hard? Are they cord-like? The vessel needs to be soft and spongy in order to really accommodate the catheter and the proposed fluids well. How long are you planning on the IV therapy lasting? Does the patient have a preference to where the site goes? And patient age can also dictate the site that's chosen. So when you are considering which site to use, consider the visualization technology to help identify the veins. There are a lot of visualization tools available, such as a light that can be placed beneath a hand or a foot or an arm to help you identify those veins. You can also use ultrasound. And for adult patients, veins that should be considered are the veins that are found on the dorsal and ventral surfaces of the upper extremities, which would be the metacarpal, the cephalic, the basilic, the median veins. And again, avoid those lateral surfaces of the wrist within 4 to 5 inches because of the risk for nerve damage. For pediatric patients, similar veins to consider would be the hand, the forearm, the antecubital area, the upper arm below the axilla, veins in the scalp, foot, and fingers in the infants and toddlers can also be used. Again, avoid that ventral surface of the wrist because of the pain and possible nerve damage to the radial nerve. Avoid veins that are in the right arm in infants and children that have congenital cardiac defects. These veins might have decreased blood flow to the subclavian artery after the procedure treating the defect. Again, site selection should be initiated routinely in the distal areas of those upper extremities because subsequent cannulation should be made proximal to the previously cannulated site. And IV sites are preferably done in the non-dominant arm. There's several things that we really need to avoid. Avoid hard sclerosed veins, the inner aspect of the wrist, an extremity that's affected by a stroke, areas of flexion whenever it's possible, the extremity that's affected by a previous pertinent surgery, for example, a woman or a man who has had a mastectomy with axillary dissection, you would not want to put an IV in that arm. Avoid metacarpal veins that have obvious arthritic hands. Avoid cannulating an area below an area of phlebitis or infiltration. Avoid areas of ecchymosis. Again, avoid the dominant extremity whenever possible. Avoid lower extremities in the adults unless it's absolutely necessary. and that generally will require a specific physician approval. There is an increased risk of tissue damage, thrombophlebitis, and ulceration if a lower extremity vein is cannulated in an adult. Avoid a previous cut down site. Avoid a hand or arm that a patient has had a graft or shunt site for dialysis. Avoid areas of pain when you palpate, and areas of valves if they're identifiable. You don't see these in a lot of people. It is easier to see it in the older adult, but if you see a valve, you may have issues with the flow of fluids. Areas that there's going to be a procedure planned should be avoided unless it's directed otherwise. And an area of radiation therapy, and also avoid an arm that has lymphedema.